You can see the asymmetry, and you can see the excess gingival display. In sitting down with her and educating her and creating that patient-specific anatomical reconstruction, we were able to talk with her and see if some of the things that we wanted to correct were some of the things that she wanted to correct. And like some patients, the more she learned, the more she wanted, and realized what it entailed, including in her the possibility of orthognathic surgery. You can see the mild degenerative changes and the change in the cortical plate. And you can see over here there the retroglossal constriction in the airway and the potential for sleep apnea. And here you see the application of the template. So we would take the template and put it against her and try to match her and digitally see if that's something that she would like to have in terms of the changes. And so when you see it in profile view, we talked to her about it, did she want to include the nose rhinoplasty, that with simple orthognathics we could improve the elevation of the tip of the nose, but the bump would still be there. We could advance the maxilla, advance the mandible, shorten the lower facial height, and rather than using some cephalometric norm, we can visually sit with the patient and get some sense as to whether or not she wants to change like that. The heart of disappointment is unexpected or unfulfilled expectations. And I remember a patient walking out of orthognathic one time to me and complaining about the surgeon. He said that he had the pictures of him on the operating room. And that's what he thought that he was going to look like. And he came out and he looked completely different. And it's hard with cephalometrics to sit with people and show them that. Sometimes in talking to people, it takes a little bit of time. And we found by adding a template, and not so much putting it in black and white like our previous studies, but leaving it in their color and putting it against these, that it brings us a little bit closer to finding out what it is they want. And so when you look at her over here, you can show her, is this what you really want? And there we can see the changes that we're able to effect. Maintaining the width of the nose, we were able to shorten the face and reduce the mentalis strain, give her the symmetry that she wanted, reduce the open bite, and normalize the occlusion. Here you see her in the oblique view with the changes that are pretty much what she expected. And there you can see the reduction in the gingival display and the development of the width of the combination of orthodontics and surgery, and the reduction of the retroglossal constriction and the normalization of the airway with an enormous change of 101% in the total volume, the retropalatal volume 98%, retroglossal volume 87%, and the transverse at 62, the choke point was almost 172% increase. And so in cases like this, where we would be tempted to do a mandibular setback procedure based on her, and maybe to correct the asymmetry, when we look at the cephalometrics on her in 2D, we see that the maxillary depth is pretty close to right on. And yet, on her, we ended up moving the maxilla significantly forward and the mandible a little bit forward in being able to reduce that malocclusion to normalize it like that. And there you see the before, and here you see the after, using that prosometric type analysis. Here would be another one. Similarly, by looking at it, we look at the nasolabial angle and we think, all right, let's impact the maxilla, maybe bring the mandible forward and give her a genioplasty. And then we ended up actually bringing her further forward based on that, versus based on, different to the cephalometric analysis, which shows the maxilla already prognathic, 2D cephalometrics. There's the open bite, and there she is completely reduced. And there you can see her before, and here you can see her after, and coming closer to what it was she wants. Here's a woman that came in with sleep apnea, and similarly there you can see the maxilla is in a pretty good position, so we brought her 10 millimeters forward, 10 millimeters forward. in order to reduce the apnea. And then she wanted to have some veneers, and you could see the results with some veneers afterwards. Very happy based on what it was she wanted. So years ago, a woman came in from the East Coast, called your neck of the woods, and she was a wrestler. And she was complaining that they were calling her a witch, and she didn't like her face. And she was getting to be well known, and so don't take away her face, but at least give her back a normal bite and take the witch out of her face. And we ended up doing a mandibular setback on her.
Report gun on the big show of the Mystery Man. And one right in front, it's China. Triple H in control of the count. China, she's a witch. And two-face she-devil. China back where she belongs. Indeed.
So here you see the class 3. I'll show you a little animation that exactly represents the surgery that we did, taking the mandible and reducing it with a bilateral sagittal osteotomy, and then at the time feeling good about it. There she is while we were going through treatment. But later on in the literature, I began to read some of the things that are relevant and recognize some of the incorrect treatment that was rendered against her based on the airway. When you look at it over here in the literature, they talk about the volumetric planar linear analyses of the pharyngeal airway space after the mandibular setback procedure, and how it will really have an impact on the airway. And irrespective of the cephalometric tracing, what we do different now is consider that. Here's another study showing the changes in the pharyngeal airway space with a Japanese woman. And so the second protocol that we've made significant changes then is in the airway, in the diagnosis. And we've talked about it a lot as far back as the slides that Carl was showing us. But 2D cephalometrics are not really accurate in assessing an airway. And we have technology today that is. So here would be an example of a class 3 malocclusion with maxillary insufficiency, darkened buccal corridors. Looks like somebody took the air out of her midface, the mandibular asymmetry over here. And in putting the template on her, she was very clear in wanting that full model look. She wanted to go into modeling. The bite was uncomfortable, but she wanted a much more fullness. And so rather than set the mandible back, we would go ahead and advance just the maxilla all the way forward. And here you see the oblique view with the filling up of the midface. There you can see the occlusal changes and the smile. And there you see the fullness that she was looking for and the like. It was not so much based on the cephalometric norms, but more so on the 3D prosometric type facial analysis. And so airway becomes a real important factor in deciding, in addition to the facial changes that we've seen. Airway is not new. Carl and Rick were talking about it years ago. Here's a book that I found, Carl, in Rick's room, Do Not Remove. It was Dr. Rick's personal copy. And it showed these little kids in airway and how he was talking about it. So in my mind, him and Rick were visionaries ahead of their time, showing us and teaching us things that we now have the technology to do something about. In our office we have a little fiber optic scope, and we put it down their nose and we can look and see what's going on. We have 3D technology that's available to us where we can measure the volume, and who's better than an orthodontist in terms of being able to screen these people? The ENTs are popping out the adenoids and the tonsils, but forgetting about the orthopedics. Sometimes we're guilty of doing the orthopedics and not doing the medical management. But the opportunity is there to do both. And we can look at the venous plexuses and the cause of the etiology, and no amount of mechanical therapy is going to relieve that. We need to address it biologically. Currently underway, the Department of Health and Human Services have launched a very ambitious project that they have termed Healthy People 2020. It's an attempt to make Americans healthier, and at the top of their list was Sleep Health 2020. And they've encouraged dentists to work with, and orthodontists to work with our medical partners and identify and diagnose and treat obstructive sleep apnea. In children, we can prevent it today. In adults, we can treat it with mandibular posturing devices or CPAP, and surgically, we can completely eliminate it using orthognathic surgery. In the orthognathic literature, as you look at the efficacy of orthognathics, it's in the range of 90+, sometimes even up to 96% successful. Here's my little son had his 7th birthday many years ago, and we've done a really good job, at least in Los Angeles, in addressing malocclusions. I think every kid at his party had braces on. But we haven't done as good a job as a profession, despite Carl and Rick and all of the others bringing to our attention in identifying airway. And we have that ability today. And sometimes we pay lip service to it, but we sometimes are not doing an antibiotic. And with the 3D, we can today. We can do it better. And with a simple little patient questionnaire, and any of the stuff that you see on the screen that you want to request from me, please just one little email to me and I'll get it all to you so that you don't have to copy any of this down. But a simple little patient questionnaire or a screening to the providers, neck circumference, craniofacial anomalies, adenoid insulin resistance to dyslipidemia, hypertension, family history of coronary disease. There's a tendency amongst lay people to think that obstructive sleep apnea is caused by obesity. And unfortunately in America, the statistics show that 66% of Americans are considered overweight. 33 are considered the BMI of obese. Unbelievable today in America. So it is a problem, but obstructive sleep apnea is not only related to overweight, as we know, it's truly anatomical. Here you see a non-overweight little kid struggling to breathe. Look at the mandibular retrognathia and the apneic episodes that are occurring. Snoring in young children is not normal. And if you identify a young kid that is snoring, you should be addressed. Watch the apneic episode stopping. And we know today that sleep apnea can be really debilitating. In young children, it will make them hyper ADD. In adults, it can create memory loss, hypertension, diabetes, depression, heart disease, and a whole litany of very severe medical conditions, all of which could be very effectively treated. In a young kid, rather than doing it orthodontically here, we're going to bring the whole mandible forward and let her breathe a little bit better while we're reducing the malocclusion. So airway does need to be included in our diagnosis.
Henry had been having problems with sleep apnea for over a year, probably closer to 2. The very first time it happened, he was about 5.5 or 6 years old, and he woke up gasping for air.
It was like I just ran like a marathon or something when I would wake up in the middle of the night, because I'd just be gasping for air. It'd be hard to get it. I'd be like all tired all of a sudden. It was just scary. I didn't know what was going on. At nighttime, I'm wearing a retainer, but nothing during the day. It's just something you put in at night before you sleep.
He didn't have to have surgery. It cleared it up with just the expander. Besides, he has this beautiful movie star smile now, but they didn't have to do the surgery or anything, and it went away really rapidly considering the point we were at with it. It was very scary.
I was really happy when I found out I didn't have to have surgery. Like, really happy.
Nice long-term records on him, but the question comes up then, does rapid maxillary expansion really have long-term effects on the airway and breathing? There's been a lot of nice studies in the literature that really has settled that question. Here's the cricket that was published years ago, and we know that with some of these removable devices, it really is not an orthopedic device. And inasmuch as they're useful and have a place in orthodontics, and this lovely MD lady, Garber, was treated with one of those, you can see the nice changes. It really is not orthopedic. And it won't have any impact on the airway whatsoever, although it may make her look nicer. Here we see some orthopedics that's done. Sometimes we do them with quads, sometimes with the Wilson, sometimes with the expanders. And what we see in the literature today is, in as much as we admire the amount of expansion that's done over here, we should catch it earlier. We should catch it earlier because you could make a much bigger difference. And with some of the TADs and the bone-anchored expansion, we can get a much more increase in the true palatal width. When you look at some of the studies that are done by Ma and the conclusions they come up with, it's a very small sample. They're too old already. 12 years old is way too old to be able to, not too old to do it, we could do it, but we could do it earlier much more effectively. And some of the results are not compelling compared to some of the results that you see when it's done much earlier that are reported in the literature. And so here you can see a patient that was waited way too late, and the varying ways of fixing it. But now with the bone, with the TAD implanted expanders, you can really get some nice change in the volume and in the airway. And here you can see some of the references to it. Dental arch dimension changes after adenoidectomy in children. Improvement of nasal ventilation after rapid maxillary expansion. They were evaluated with computational fluid dynamics, rapid palatal expansion, and does rapid palatal expansion have long-term effects on the airway dimension and breathing? And we know the answer today. We remember back as far back as Stenlinda Aronson came and spoke to our group. There was a prospective cone beam tomographic. Tongue posture improves as the pharyngeal airway enlarges, a secondary effect of maxillary expansion, and some of the literature to support that doing it. Three-dimensional and on and on. And please, I have the, I think it was years after that very first meeting, Carl, that we invited Stenlinda Aronson Warren, you may remember. And he and Woodside had done a lot of the early studies and talked about it as far back as that. Oh, something is... I've lost a connection for some reason here. Do we have lights out so that we can see? It may have been down there somewhere. I just lost a little connection. There I am again. Thank you, sorry. Very good. Sorry about that. There it is. So there is that same patient that you see with early interception and orthopedics, like we had talked about, developing the width. And at this stage, at full maturity, we can go on and put some brackets on and finish her off pretty nicely. Here is a patient that came in to see me. His dad is a friend of mine. He's an architect. He recently built a beautiful studio in my back garden. And I treated him with what I felt like was a real beautiful result at a young age. And about 2-3 years later, he comes in, and he's got an open bite. And I'm thinking, oh my God, what in the world is going on? Here I am keyed into occlusion. I'm keyed into all the things we talked about. I'm keyed into airway, and right in front of my own eyes, my good friend, the architect's own son, he's sitting there with a big old open bite and a long face syndrome. So sometimes we talk about it, but we don't always pay attention to it. I'm going to show you. So here he is, long-term, young kid, beautiful result, beautiful occlusion, slowly over a period of time, opening wide up. Airway problem, mouth breathing. As the person is opening up his mouth, tongue position drops, arches begin to constrict, bite starts to open, orthodontist's work goes out the window. And I'm going to show you later in the presentation how we ended up treating him. You try to tell my best friend after a couple of years of orthodontics that we have to do surgery on his young son. He wants to know what happened. I'm going to show you what we did to fix it. Here he is with that really severely retrusive mandible, and you can see with a severe open bite, you can see with a cross bite as it's constricting. We know with cross bites in the face of bad hygiene what happens to teeth, or what can happen, and we prefer not to leave it. Some things less talked about with the cross bite is the crowding that occurred and the danger of impaction of the canines, and the tendency for people sometimes to then want to take the teeth out rather than address the airway. And here we see the cuspid lurking dangerously against the root of that lateral incisor. And this was a patient that transferred in to our office when it was too late. Look at it. Something none of us want to see. None of us want to see that. There it is. 2 lateral incisors need to be extracted. Dad is an attorney. It's his only child, and he wants to blame somebody. I called the dentist, and I said, why didn't you send her in earlier? He said, it looked pretty good from the outside. Ended up all being fine and settled out okay, and everybody was happy. And some of these things are not 100% preventable, but really in our heart of hearts we know that it is. And here we've got a woman now that has no lateral incisors, a very complex malocclusion. She's congenitally missing some teeth. She's got airway issues and a dolichofacial tendency, and now she's one of those cases that Carl talked about that's a hard one to fix. Here's another case, by contrast, that's equally complicated, that was intercepted early, but even maybe too late. You can see canines lurking dangerously close to the central incisors. But they're caught. 9 millimeters of crowding, no space, could have been intercepted way earlier. But even with that late stage, we can successfully go ahead and bring it in and imperceptibly land it into position on either side if it's managed correctly. The late editor of our journal, Vince Kokich, had approached me before he passed away so tragically recently and asked me to write an article on treating sleep apnea, the case of the surgery. As you know, it's the point-counterpoint, and he wanted me to take the position of surgery, although of course we use mandibular posturing devices and we're very much in favor of them. But for adults that are coming in, a simple Epworth sleep scale is an easy first screening for your patients to identify their tendency to want to have sleep apnea. We now have at our disposal, and have published all of the norms on airways. We did a study of 1,700 of our patients. 1,300 of them were published, but we actually measured the norms from 6 all the way up to old age. And we found one that from age 10 to 20, the airway increases a little bit, gets a little bit bigger of all these patients. From 20 to 30, we found that it stabilizes and stays the same. From 30 onwards, what do you think happens? It gets a hell of a lot smaller. And by 40 or 50 or 60, they have the airway of a 12-year-old. And now you find that a person with a very young airway, you know it's not going to get bigger, so we need to address it. And we have a way of measuring that. So we've got the Epworth screening scale. We have 2D cephalometrics is not accurate in identifying airways, and mostly because you're looking at it just in one dimension and you don't see the volume. You're going to get a false positive and a false negative. They look like sleep apnea, and from the other side it's plenty of air, and vice versa. They look beautiful and big, and you look at it and there's nothing in the transverse. You really need the volume, and we have the ability to do that today right at our fingertips. And it's all published. Here's another article that we have showing it. We're showing the studies. We actually took a phantom and we measured the phantom hair, and then we measured it on the CBCT, and Steve Schendel and Dave Hatcher did that study and validated the methodology before doing the study. Similarly in the nose, I had Steve take a little radio frequency probe, and he just shrunk my turbinates. And I breathed so beautifully. I remember on my honeymoon, I was sniffing and struggling, and I wish I would have done it 100 years ago. It's so easy to do. So we pay tribute, we sometimes pay lip service to it, but now we have the ability to measure it and do something about it. Multivariate analysis shows both the retroglossal space and the retropalatal space can be predictive of respiratory disturbance index. Probability of severe OSA is very high with an airway of less than 52 millimeters. And so we can place, here we can see the tongue pushing back against the oropharynx. There we see the velopharynx, nasopharynx, and the laryngopharynx. And as we advance that mandible, the uvula stops vibrating as much and snoring, and the airway increases nicely. And it can be controlled with the mandibular posture device quite well, to the point where the next morning they wake up and they feel better. And sometimes, because they're not as healthy, it'll be a little ramp up in terms of them better and better. And they'll get to the point where they'll call you, and if they don't have the appliance, they really want to be with it because it feels so good. The compliance with the CPAP is really not great at all. When you look at the studies, it's not very well tolerated. When you look at the literature, a little more effective than the mandibular posture appliances, if they use it. But if they only use it at 4 hours out of the 8 or 6 out of the 8, and they throw it off in the middle of the night, you've got 2 bad hours. Compliance with that mandibular posture device is all of the 8 hours. It'll match it or beat it. And so from mild to moderate apnea, that mandibular posturing device is a very effective appliance and an alternative to CPAP. The gold standard is still polysomnogram, and so it's useful to get a study done where you measure the oxygen saturation. There's many different models of these on the market, and they can be made right in your own lab. The mechanism of action is how it enlarges the airway, surprisingly not only in the anteroposterior, but more so in the lateral. It really does an enormous difference in the lateral dimension. It also improves the muscle tone, and the negative intraluminal pressure is required to close the airway, so there's decreased collapsibility as a result of the posturing forward. So then lastly, the teeth and the occlusion. We've talked about the face and the advantage of a template, aesthetic template versus just 2D cephalometrics. We've talked about the importance of the airway, and lastly, the teeth and the occlusion. Carl touched on it a little bit today. Debates in the literature continue to raise even as far back as dental school, where the cuspids were placed. I remember finishing my first case with 2.5 millimeters of overjet and 2.5 millimeters of overbite, and bringing it to one of the prosthodontists, and he said, "That's nice." Started out at a deep bite, and he said, "That's nice, now can you go ahead and deepen it?" He wanted Bob Lee's 5 millimeters of deep bite with incisal protection. And so philosophies continue to vary, and we've made as a profession some nice improvements since Angle's day, and Brody and Tweed, Andrews came up with these straight wire appliances. Dr. Ricketts, Dr. Gino, and Roth added to it. And as, like what Carl talked about, they moved towards more an individualized prescription, over the years we've been able to get a little closer to what we want. I sat next to Larry Andrews at Dr. Ricketts' advanced course, and he showed me his book and his statistics. And when you look at his raw data, you can see the huge variation in torques of the upper incisors and angulations on the upper cuspids. And virtually every one of the measurements that he published. And so he sort of averaged them out and came up with what he felt like was his straight wire appliance. He puts 3 degrees on the central, and Roth will put 7, Carl and Rick would put 14 and 22. Similarly on the cuspid, some people would have, Andrews would do -7, Roth would put it at 0, Rick would put it at +7. He was right. We know today that it depends on the patient and the individual. And so, to forward the progress, Rocky Mountain would come up with a synergy appliance where you could have 3 different prescriptions and you could ligate it differently, and in order to try to match the facial profile of the patient, which in some ways was a step in the right direction. Now we have 5 or 6 or 7 different companies. SureSmile, you're all familiar with it, with robotic formed wires. Is in an attempt to try to individualize prescriptions in order to make it a little bit more specific for the patient. Here's Insignia, Omco's, where they go ahead and take a look at that. Where we can have a number of the companies have the software. Great Lakes, recently I just picked up theirs and I'm working with their software, where you could take it into your own office and just do your own digital setup, however you want it. You want to put in a little overcorrection, go ahead. You want to have a little bit more or a little less talk, or right ahead. And then you can use on 70% your pre-adjusted appliances, but on some of those you may want to have a much more individualized type of an appliance that'll get you closer. When you look at the statistics that they're putting out, there you see they're cutting individualized slots for every single patient. There's a company doing it on the lingual, Omco are doing it with Insignia, SureSmile are doing it with robots. Great Lakes are not really offering that service yet, but they have the technology, and it's a matter of picking the one that you like. Here you can see the individual wires. Rocky Mountain years ago came out with 5 different arch forms, but they're taking it one step further, and now we have the ability to pick and choose specifically the arch form that you particularly want for that particular patient based on their periodontal condition or their skeletal condition. So you can see the jigs that we currently use in the office, which will, in those cases, if you want to enhance the results in less time chairside, because it's all done before, you can walk right in. And I like putting them on myself, but in many cases you can have your assistant put it on, cure it, because you've pretty much done the diagnostic setup yourself. I like the touch and the feel, and I like to seat it, and I like being in the chair, but it's personal preference. There you see the seating of the actual jig. You could do it direct or indirect. You'll see in a few moments a custom jig that we can make right at chairside in our own offices. If you don't want to go through one of the commercial laboratories. But it really does allow you the opportunity today to specifically individualize your prescription. So exactly your patient, and the chairside process is pretty quick. They come off. Some of the older ones are a little harder to come off. Some of the newer ones that we have now are just a lot easier. And that's essentially the process. Here's for some of you that may want to do it right in your office. I'll take a little bit of blue acrylic, and you can place it right on the tooth that you want to change. And you could take a little 16 square or 1622 alloy wire and get it in there. Put it in your bracket. You can attach 2 or 3 or 4 of these at a time and put them on in minutes. Easy to do. And you can change the torque and angulation and offset however you want to, based on your diagnostic setup, which you could do by hand if you want to. We like to do it digitally because we have that ability, but every now and again there's a place to be able to do that. So lastly then, I want to talk briefly about accelerated orthodontics using a modality that has significantly reduced the amount of treatment time that we didn't really have available to us years ago, and that would be the piezo surgery, with or without orthognathic surgery. Well, I think you were in our office at one of the courses one time where Dr. Ricketts was doing a corticotomy, and he would take these horrendous malocclusions, and he would go right in the office and cut away the palate and take a burr and take away that big thick bone, and then he would go ahead and reduce the class 2s. And in some sense he was ahead of his time, in that he may not have explained it as the regional acceleratory effect, and in his mind he was taking away some cortical bone, but maybe it sort of led the groundwork to some of what we're doing today with some of the corticotomies. And we're using it fairly extensively in the office today. When you look at the literature, the effect of piezopuncture on tooth movements is quite compelling. It's been tried first in animal studies, and it has been debated in the literature. You saw recently where the Wickedonic crew were debating the case 4 corticotomy, and the late Vince Kokich was talking about some of the perhaps reasons why he was overly aggressive and he was less. Vince was a little bit less enthusiastic about the aggressive approach that Wilcox was using with the full thickness flaps and the extent of the surgery. They also disagreed in the methodology, or the biochemistry and the biology of the tooth movement. And it's been nicely discussed in the literature. But what we do know is that it works, that it does work. And one of the things that we ask is, well, how much of the surgical insult will affect the bone around moving teeth? In other words, if you do a little, does it matter if you do a little or a lot? How much piezo should you do in order to get movement? Does it make a difference? And they did in this study, a nice study where they did they did a little and then they did a lot, and they found that increased surgical insults produce less dense bone, less mature bone, but has no effect on bone volume. What they mean is, at the end, it didn't really affect the total volume of the bone. So the quality of the bone was good, but yet the more injury you did within reason, the better results you got. So a little simple puncture is not going to be as good as a real cut. This was basically what they were showing. And so here I'm demonstrating it on a skull with a little piezo that we use in the office, and we'll go all the way up. And it cuts really quickly and fast. It's a very quick and simple procedure for an orthodontist to do in his office. If you want to use a handpiece instead, you should use a low torque handpiece. And you could essentially mimic it with a handpiece, although it's not quite